Thank you all for coming. Can you hear me okay? Yes? There we go. So, welcome to SNOW 2022. Thanks for coming out early this morning. We have an excellent session for you all. This is digital pathology and artificial intelligence. We have a great lineup of speakers. We're still waiting on one of our speakers to show. He'll probably be moved to the last session, but we tried to invite speakers that were obviously all experts in the field and also gave us a broad view of AI and pathology. And our first speaker is going to be Dr. Sandra Camilo Paragua. She comes to us from my home institution, University of Michigan. She's a professor of pathology, and she specializes in neuropathology. She did her fellowship in neuropathology at Harvard, and she has been at the University of Michigan, being our main neuropathologist since that time. So she's going to be talking to us about AI techniques used in the operating room. So thank you all very much.
Good morning, everyone. Do you hear me well? Hope you don't see me, but hopefully you hear me, okay? Thank you for inviting me. This is a privilege. I have had the honor and opportunity to work in close collaboration with our neurosurgeons, Dr. Oringer here in the audience and Dr. Holland at the University of Michigan in this cool new technology of optical imaging that I'll be talking to you about in a minute. So the talk today is going to be a little bit about the evolution of that collaboration. So I'm a neuropathologist. I'm not a computational biologist. I'm going to give you my perspective and kind of like what I see the value of this in clinical practice. So the objectives of my talk is that hopefully by the end of this talk, you understand the value and the current challenges of intraoperative consultations for neurosurgical specimens. Recognize that Raman scattering histology is an optical modality that produces intraoperative images for pathology interpretation. And I will attempt to provide a brief overview of the utility of artificial intelligence in intraoperative consultations. So what is the importance of pathology in the operative suite? So in my opinion, it's twofold. One is to secure procurement of lesional tissue. And two is to provide sufficient information to the surgeon to decide what to do next. So in order to accomplish that, we have to answer several questions. Is the specimen diagnostic? Does the specimen explain the clinical and radiologic presentation? Is there sufficient material for final diagnosis? Is the specimen representative for additional testing? So we have to keep all these things in mind when we are providing an intraoperative consultation. In addition, we have to guide the surgeon of what to do next. Is the surgeon in the lesion, or do they have to reposition their navigation system or something? Is the lesion a resectable lesion? Is a maximal tumor resection needed or desired? Or is it better for them to just pull off and treat with other therapies, for example, in the case of a lymphoma? And again, is additional material needed for testing? And will the type of lesion determine any intraoperative treatment? Yes or not at the moment? We'll see. So what is the current workflow for intraoperative consultations? So once the surgeon procured the specimen, it's sent it to the frozen section room. We received it, and then we, oops, I'm sorry, just move. There we go. There we go. So we received it and we grossed it. We grossed it there. Some of us do some cytologic preparations, and then the rest or part of the specimen is freeze and cryosections are obtained from that. And we do a very rapid H&E staining that takes about 3 to 5 minutes. And finally, the slides are given to the pathologist for interpretation. So for us, by the time we receive the specimen to the time we provide an interpretation on that specimen is somewhere between 15 and 30 minutes. To the neurosurgeons, it feels longer, believe me, right? All right, so what are the major hurdles to provide appropriate intraoperative consultation? Well, neurosurgical specimens are very small and they require expert technique for sectioning. The real estate is very valuable, right? Rebiopsy has major risks, so we better get it right the first time around. Not all institutions have board-certified neuropathologists, and not all general pathologists feel 100% comfortable with neurosurgical specimens. In addition, the freezing artifact may affect interpretation, and the current workflow is relatively time-consuming. So here, I'm just going to show you a couple of freezing artifacts that we have to deal with and either overcome them or, that might be a big hurdle for providing a diagnosis, and we may have to require another sample if possible. So here in the top panel, you see a freezing artifact. So this is unreadable. Nobody's going to be able to tell you anything about this. Here in the second panel, we just have this kind of tissue folding and knife artifact. This can be overcome with just sectioning again, but it will require more time. And again, this highlights the importance of having a good technical person that is cutting these specimens. In this other panel here, you can see how the tissue, part of the tissue has this freezing artifact and the other part was properly frozen. So we only have part of the tissue to interpret. Or sometimes we have some sort of stain precipitate that may or may not interfere with interpretation depending on the clinical context. So this is just to give you an example of the different things we have to deal with during intraoperative consultation. It's a high-pressure environment, and we need to produce a diagnosis that is meaningful and information that is helpful for the surgeon. So what about then using non-destructive imaging modalities? Could we do that? Well, yes. In fact, there are many. There are several out there. And I'm going to focus later on stimulated Raman scattering microscopy. But here is a list of the College of American Pathologists of different types of techniques of non-destructive imaging modalities that have been used in different tissue organs. So what are the advantages of this type of modalities? Well, first, they can be used either in vivo or ex vivo. They use fresh tissue with none or minimal tissue processing depending on the technique. There is no need for sectioning as the images are obtained in a specific optical plane. And they all can produce digital images for either on-site or remote interpretation. Now, the quality of the image is going to vary depending on the type of the modality. So the optical contrast of these modalities relies on the intrinsic optical properties of the tissue and usually not on a specific staining. So in terms of stimulated Raman scattering microscopy, this is a technology that relies on the intrinsic vibrational spectroscopic properties of the molecules. So the molecules vibrate, and when they move from a resting to an excitatory state, they change their spectra, or what we call the spectra, and that's called a Raman shift. So we've been able to hone two different Raman shifts that are important to evaluate lipids, protein, and DNA. And here you can see some images of that kind of raw images of acquiring. And those raw images, and again, these are from fresh unprocessed tissue, right? So we decided, okay, why don't we virtually color those images so that it looks more appealing to us pathologists and something more similar to what we're used to. And so we decided to virtually color those images that resembles H&E, and we call this stimulated Raman histology. And I'm going to show you a couple of examples of how that looked like. And if you're familiar with histopathology, you will tell me if that looks something similar or not to what you're used to. But what is the current workflow for SRS microscopy? Well, the technology has advanced so much that now we have a portable microscope that is very compact and can be transported either within ORs or it can be in the frozen room, depending on the setting in your institution. And then the neurosurgeon procures a specimen, and the fresh specimen, is directly placed in a slide, right? The slide is a loosely covered slip just to keep the tissue in place, and put into this closed system, and a non-destructive image is acquired. Within minutes, we will see this digital image that can be either interpreted in the OR or remotely. So here I'm sitting at my desk, sipping a cup of coffee that you don't see, interpreting that digital image. And all this happens within about 3 minutes, compared to 10 to 15, 15 to 30 minutes that it may take a regular frozen section. So let me just show you a couple of images about how SRH look like. So here are some examples of normal brain. On the top panel, you see conventional H&E, and this is cortex. We have our beautiful pyramidal neurons, some oligodendrocytes, these round fried eggs, and then some astrocytes. And below we have an SRH image that highlights those pyramidal neurons, and we have this lipofuscin that is very bright, it's very rich in lipids, so therefore we see it very bright. And then some oligodendrocyte and astrocytes. But more importantly, you see those white lines. Those white lines are not artifact. In fact, those are axons that are neither rich in DNA, protein, or lipids. And that becomes extremely important in neuropathology because it's going to help us determine, for example, if a lesion is infiltrative or a relatively well-circumscribed lesion. And on the other panel, we have basal ganglia. What I'm trying to show you here is the beautiful pencil fibers of Wilson, those white matter tracts in the basal ganglia, and concomitant down here on SRH. Well, what about tumors? Well, here is an example of an oligodendroglioma grade 2. Well, I don't think any pathologist will be able to tell you that this is an oligodendroglioma on this panel. This is a beautiful frozen section, in fact, very well done, no artifacts in general. We're able to tell you this is a hypercellular lesion, most likely an infiltrative tumor, because there are some like perineural satellitosis around here. So, you know, infiltrating glioma, that might be good enough for the surgeon. But let's compare the same piece of tissue with Raman microscopy. So this is the same tissue obtained at the time of intraoperative consultation, and you can appreciate how the cytoarchitecture is preserved. We can see that not only the tumor is hypercellular, but in comparison to the frozen section, we see that in fact the nuclei are round. They are not squiggly, right? They are round, they are fried egg-like appearance. I hope this is kind of a buzzword for you. And we are able to also see these beautiful, thin, delicate chicken wire capillaries. But most importantly, notice all these white lines. So we are able to see that there are plenty of axons that are traversing the lesion. Therefore, this is an infiltrating glial neoplasm. And down here, you can see those fried eggs. In this case, those are like the green eggs of ham of Dr. Seuss. Anyway, they are not clear, but rather darker, that are going around neurons. So it's not exact correlate of H&E, but it's pretty similar. And then on this side, we have microcalcifications. Well, let's see how this compared with permanent sections. So 1 or 2 days later, we received this beautiful histology of formalin-fixed paraffin-embedded tissue. And you can see how we have our fried eggs. These are not from Dr. Seuss. Those are from our kitchen. And they are very nice, round eggs here that are very comparable to what we obtained at the time of intraoperative consultation, right? And here you can see the microcalcifications and again, the perineuronal satellitosis. So what I'm trying to show you here is that SRH is producing optical digital images that are very comparable to conventional H&E. And here is an example of a glioblastoma, again, multinucleated cells, pleomorphic. We're able to identify mitosis, microvascular proliferation. An example of a meningioma that has beautiful lobulated architecture, some intranuclear inclusion, whorls, and samoma bodies. And a couple more examples here for you. This is a pilocytic astrocytoma. What we have, so pilo is these long hair processes that you see here beautifully. We have these bipolar processes here going around, and we have numerous rosenthal fibers. This is how rosenthal fibers look on SRH. But most importantly, note how we do not see those white axons traversing. Therefore, this is a relatively well-circumscribed lesion, extremely helpful. Most of those lesions benefit from complete surgical resection at the time of surgery, right? Here is another example of chordoma with these beautiful physioliferous cells, those clear bubbly cells here. But don't take my word for it, right? So we did a study trying to determine if those images were really amenable for pathologic interpretation. And we did a prospective study in which we divided the samples in half and, sent half sample for conventional H&E and the half sample for SRH. And then collected whole slide images of those frozen sections and also digital images of SRH, and then give it to 3 different neuropathologists with all the information that we received at the time of intraoperative diagnosis to see if pathologists were able to provide an interpretation. So just a quick summary is, yes, they are, right? We are able to do that. We obtained a combined accuracy of 94%, and pathologists were able to provide a diagnosis in either conventional histology and or SRH images. So this is great, right? So now I think I have shown you by now that SRH are amenable for pathologic interpretation. The next question is, are those images then perhaps amenable for coupling with AI kind of architecture and predicting diagnosis in a similar way that a pathologist can do? Well, that is easier said than done. But here is a summary of what happened there. And this work is a work mostly performed here by my colleague, Dr. Holland. And the images are acquired, as I previously mentioned. And then those images are processed in this slide window algorithm, where basically high resolution and high magnification overlapping patches that you can see here are gone through this algorithm, and this produce these very high resolution images that are then passed through a neuronal network that is used for either training and prediction. So this neuronal network was modified to output 13 different categories that I'm going to show you in a minute. And then the output is going to produce kind of a heat map of a probability of diagnosis within those categories. So we teach the computer certain categories, and it's going to tell us, oh, the probability that this patch is a meningioma is X, the probability that this patch is a lymphoma is Y, and etc. So we get a heat map and then a final kind of prediction probability of what this could represent. So here, I'll show you that the training for that was done with more than 2.5 million patches in more than 400 patients, and that included 13 different categories. That included normal, which is gray matter, white matter, and gliosis, and 10 different classes of the most common tumors on the CNS. Then we did a multi-center prospective clinical trial that included 3 major academic institutions here in the United States, trying to identify if coupling SRH with CNN will produce diagnostic categories similar to what the pathologists will do with conventional histology. And in a quick summary, and I'm just like only showing you the highlights here, was that yes, indeed, that SRH coupled with CNN is non-inferior to pathologists reading conventional histology with an overall accuracy that is pretty similar to one another. So I guess by this point, I have shown you that SRH images are, one, amenable for histopathologic interpretation by a human being, but also by histopathologic interpretation by a machine that produces similar results in certain given categories. So the next question is like, okay, that sounds pretty cool, right? However, with our naked eye, we cannot determine what is the molecular milieu of those tumors, right? So could it be possible to use AI to predict molecular features of gliomas? And, we decided to go for the low-hanging fruit and focus on the most common type of adult diffuse infiltrating gliomas, okay? So we decided to ask this question on a set of adult diffuse infiltrating gliomas, basically those that are either IDH wild type or IDH mutant and either 1p19q co-deleted or 1p19q intact. So obviously, I don't think any of us can tell which one is which here. So again, easier said than done. But the laboratory of Dr. Holland has developed a system in which coupling SRH with CNN are able to provide a diagnostic molecular category of tumors. So this is called deep glioma, this system, and it's composed of 2 different encoders. So first, an SRH encoder, and 2, a genomic encoder. So the system has to learn the images, right? So it has to learn like, okay, this image represents X group of tumors, but then it has to learn the genomic milieu of what is it in this tumor and how does it work? So, well, it learned from publicly available data sets, in fact, more than 2,000 publicly available data sets of there. And what it's trying to learn is not only is this tumor mutant for X or Y, but it's also trying to learn what are the correlations of the different molecular alterations within a given tumor, Can Sandra live with Jeff, and Jeff live with Pedro, and Pedro and Sandra are a family, so therefore they belong to this Camelo family, right? So that's what it's trying to learn. And then these 2 different encoders are coupled together in a single architecture to try to predict that. So on this panel, you're gonna see how these 2 different encoders are combined for both training and prediction of whether a piece of tissue represents a specific category. So how it works is that each patch, again, is going to give us a type of prediction of what it could be. So for example, in this tissue, so this is a heat map here, right? So here in the bottom corner here is probability of this tumor having an ATRX mutation. So this is a heat map, and blue is kind of cold. So the probability is very low. However, if we look at the 1p19q codeletion, the probability is very hot. And then if we look at the IDH mutation, the probability is very hot. So in combination, if we overlap this kind of Google map, if you imagine that, this is a tumor that has a low probability of an ATRX mutation, high probability of a 1p19q codeletion, and high probability of an IDH mutation. And it looks like an infiltrating glioma. Therefore, most likely this is an oligodendroglioma. So this is how it works, just to give you a brief idea. So what happened next? So this was the training database was performed with more than 300 cases, and then the testing data set was performed in an international multi-center prospective study. And all this data that I'm showing you right here is unpublished, but under revision, and hopefully you will be able to read it in print pretty soon. Tell us what you think about it. So here the summary is that this deep glioma system is pretty good in accurately diagnosing tumors that are IDH mutant and 1p19q codeleted, and decently so with ATRX mutation, as looking at individual molecular alterations. Overall, we have an accuracy of diagnosis of 91.5% when we look at all the adult patients, and the accuracy goes all the way to 94.4% when we look at patients under the age of 55 that, as you know, are heavily biased towards IDH mutant tumors. So this is just a proof of concept. We're not trying to replace anything, but just trying to show and demonstrate that, in fact, SRH images I have shown you, they are looking like H&E. They are amenable for pathologic interpretation either by humans or machine. And now we're trying to show you that they are also amenable for molecular subclassification, at least of adult diffuse infiltrating gliomas at this point. So the next question is like, well, not everybody has an SRS microscope, right? They don't have the ability to have access to that. Could we use the same principles in what we have in daily basis? Well, a lot of studies have been done using whole slide images of permanent, beautifully nice tissue, but what about frozen sections? That's where the dilemma is. When we have the beautiful FFPE, 3 days, 20 stains, and all the molecular at our fingertips, no biggie, right? The question is those 5-10 minutes to give information to the clinicians. That is important. So we decided to investigate this, and we have a very large collection in our institution of more than 2,000, in fact, slides on frozen sections. So we wanted to see, can we predict big major diagnoses? We're focusing like carcinoma, meningioma, metastasis, lymphoma. Can we put in these 4 big categories? Well, guess what? It's very challenging because we are introducing a lot of different artifacts, right? So also there are no big data sets out there to train. We need a lot of data sets to train the system and teach the system how to predict those things. So we collaborated with a company that is helping us produce faked, artificial, synthetic images of tumors. So for example, here on this side, I show you the conventional H&E of a given tumor, and then they are able to learn from different histopathologic features of that and produce a fake image that can then be used to train the algorithm. So basically, it's going to give us 1,000 images of an astrocytoma, for example, to help train. And when we do that, the accuracy of predicting diagnosis on those 4 categories goes really high. Again, this is just preliminary data. We're still working on it, but I just want to show you a proof of concept of using artificial intelligence, not only on SRH, but also on something that is more accessible to us pathologists. So in summary, I've shown you that intraoperative consultation for neurosurgical specimens require skilled histotechnologies and very well-trained pathologists that needs to deal with numerous artifacts that are introduced during the freezing processing. SRH is an optical imaging technology that acquires digital images on fresh, unfrozen, and unprocessed tissue within minutes. And SRH images, as I told you, are amenable for interpretation by pathologists, but also by AI, and can produce or help us determine molecular subgroups of adult diffuse infiltrating gliomas. And finally, AI can be used on whole slide images of neurospecimens to predict major diagnostic categories, at least in a preliminary fashion, as we are. So that's all I have for today, and I just want to thank the collaboration. I think this is the most important thing, is to be able to collaborate and talk to colleagues in different specialties, learn from each other, and move the field forward, hopefully. And thank you for inviting me today. Any questions?